ahead and here's a call to Newcastle. This landmark study that was done in Kaiser, where only Kaiser for a long period of time had the data collected over time, so that Dr. Folletti could look at a variety of early childhood adverse circumstances and ask parents about them, and then look at the health of the individuals responding. And what he found is there was a graded dose dependent response to all kinds of adverse outcomes. And they included adverse behaviors, smoking, substance use, early sex, future violence, unintended pregnancies, and then all kinds of adverse health consequences, including mental health-related suicide, depression, but also plain organ health, not just obesity, but heart disease and liver disease. And putting it all together, and as I said, the number of these adverse circumstances, if you add them up, when you got to 6 of them, your chances of dying earlier, you would die 20 years earlier by the actuarial tables, so to speak, the study data. And then it's been said that up to 40% of early deaths in this country are related to ACE. And this has really gotten a lot of attention around the country, and even congressmen and all kinds of systems like Kaiser. That what can we do about averting these terrible outcomes? So it's not just sometimes there's big data, and big data you'll find stuff, and maybe these just are associations, but increasingly there is evidence for neurophysiologic and general physiologic mechanisms for these kinds of outcomes. And that includes gene-environment interactions that can affect lifelong behavior, development, and health. Now, this comes from animal studies where they're mice and monkeys, and they're varying nurturing conditions that are set up, and those are associated with differences in neural functioning, later cognition, later stress responses, and a variety of psychopathologic behaviors, and changing of the individual DNA. So we're used to saying, well, it's all in the DNA. DNA causes these behaviors, but in fact, it was the environment through an epigenetic mechanism, somehow methylating or creating histones, that caused DNA changes without changing the DNA sequence. So this stress gets under your skin, so to speak, and it can go on to the next generation, and even stress to the fetus in these animal studies has effects on later stress reactivity of the offspring and then in subsequent generations. And in humans, we've learned more about a variety of studies pointing to a similar pathway. That is, early exposure to maternal stress in particular affects future reactivity to stress. And what's happening is we are the normal stress reaction that is part of our homeostasis, the HPA axis, the hypothalamic pituitary adrenal axis is activated, and steroids are elaborated, and that's a normal homeostatic mechanism. But when there is, it's called allostatic, that is outside the individual persistent stress, it can affect actually the brain structure. And it turns out that in those structures that are high in steroid receptors are most effective. And you can see changes in the amygdala, which seems to be associated with more anxiety-related hyperactivation. there's prefrontal cortex atrophy. Now, you know, that's the place that is in charge of our executive functioning and involved in ADHD control. So there's less control, smaller part of the brain now. And then a consequence of hippocampal reduction would give us impaired memory and mood control. And then we're affecting the stress-regulating physiology, learning new skills, developing the capacity to make healthy adaptations to future adversity. So from this kind of neurophysiological exploration, the term toxic stress has come to mean the unit of stress that, in fact, were the underpinnings of the ACE data collection. And it's been defined the following way: an excessive or prolonged activation of the physiologic stress response system in the absence of the buffering protection afforded by stable, responsive relationships. So it's not the adversity per se, it's the absence of parental buffering that produces a kind of biological memory. That is the scarring of our nervous system that it will have an effect. The examples of these things are child abuse, neglect, parental substance use, exposure to parents who are depressed. So, but you know, all of life has stress, and it's important to notice that there's some stress can actually be growth promoting. So the concept here is that there's stress with some amount of this adult buffering protection. For example, growth promoting stress would be you're going to get a shot and your parent is there and you got through it even though you were frightened and you were really worried. It's the first day of school, but mom was there and got you through it. You survived it. Each day you got desensitized to going to school. So when they're classified, environment of stable, supportive relationships, the opportunity to learn, practice these things, and you get an adaptive response. That's growth promoting. Then there's all kinds of stress that's really not growth promoting, but can be tolerable. The concept is, and you can reduce the risk of that particular stress, like a death of a family member, if the other members of the family are supportive. Even serious illnesses or injuries, and contentious divorces, people get through those things. Natural disaster, even active terrorism. We know that people can get through these things when the supportive adults are around. Another way to think about how this kind of nervous system shock gets, toxic stress, is that what you said? It gets moves forward. If you think about you have a bad way of dealing with stress, you don't do a good job of it, and then you hit teenage years, and the kind of coping you come to your teenage years with is putting you at further risk. And so one way to think about even teens are more likely to use alcohol, tobacco, substance use, eating disorders, promiscuity, gambling. That what's happening there, maybe that's a kind of stress coping that's going on. It's trying to maladaptively cope with stress. And then they find themselves at risk for school failure, gang membership, unemployment, poverty, homelessness, all those bad things that can happen becoming a single parent. And so these high-risk adults are then that's able to provide buffer and support to protect their children from the damages of toxic stress. Everything here made worse, again, by social disparities. So this is the kind of trajectory that we're thinking about, the mechanisms where stress in early childhood produces bad things and later in life. And so all this has led the American Academy of Pediatrics to call for an expanded role, that was 12 in dealing with ACE, toxic stress. And then in 2013, there is a call for screening for parent and child ACE during well-child visits, and for us to take a two-generation approach, not just the child, because we can't manage things unless we are addressing the parent and helping the parent as well. So there's a good case for routine primary care screening for things like intimate partner violence, other adverse exposures. The case is that they're high frequency, not even if you go into low-risk populations in the suburbs, it turns out there's a pretty high frequency of these kinds of things. It has a clear predictive power for subsequent health problems. It's associated with risk for child abuse, and there are concerns that these things will not be identified without screening. And, as I said, there's a strong case for causality. So all of that, Charlotte, are they screening for ACE in Kaiser?
Not with a formal approach, at least that I'm aware of.
Okay, so I'm going to, let me tell you our approach. And you know that we are always interested in screening. And let me show you that, I'll show you that something about the questionnaire, and we'll consider further whether we should screen or not, because I'm not sure. I'll tell you more about it. Basically, ACE questionnaire asks about exposure before the 18th birthday for a variety of bad things: physical, emotional abuse, neglect, sexual abuse, household substance abuse, having an incarcerated household member, domestic violence, parental separation or divorce, and parental mental illness. This is what it looks like, just to give you an idea. It says how did a parent or an adult in the household, often or very often. Then it gives you details. They'll swear at you, insult you, put you down, humiliate you. That's the emotional abuse, and so forth. So it does give you, it does talk about often or very often and ever in terms of when we talk about sexual things. So that's an idea of the ACE screen, which is the one that was used in the initial studies. So now I want to give a case against screening for parent ACE. I would assert that there's a pretty good case against screening for it. And first of all, there are no controlled trials examining the impact and outcomes, either beneficial or harmful. We don't have any data or that it's valuable to screen for parents. And then we have the auspices in pediatrics to do such a thing. And what do you do as a positive to the parents, to the children? Are we going to try to help the parent not get liver disease? Does that become the purview in pediatrics? What do we do about it? And these are really difficult conversations. How do we start talking about this stuff? And then, is this an appropriate use of primary care time? We've got all kinds of other time is the essence of primary care, well-child visits. They talk about one more thing. That's what the pediatricians talk about. And then there are issues of safety and avoidance of harm. If we discover something and like intimate partner violence and the spouse gets angry, maybe there's more harm. Maybe so anyhow, but with all the reasons not to screen, everyone agrees on this. There's no doubt that we should respond to these issues if they're raised spontaneously. So that's what I want to talk about. How do these issues get raised spontaneously? If a parent said, "Look, I want help. My partner is abusing me, and it's not safe for the kids," of course we have to act. So what I want to talk about is how to create a conducive clinical environment for spontaneous calls for help. And I don't know if you can see the slide. Can everybody see the slide? I'm asking whether technology, I've got a doctor who has doing too much screen time in the office with the patient. So can technology help, or can it get in the way? And this in this scenario, you see it clearly getting in the way. The parent doesn't seem like it's a relationship with the back of his head as the way to express things where there's ambivalence. An approach I want to raise here is something we could call narrowing and then broadening the agenda to include issues of parenting. Okay, so basic framework for well-child visit discussion part, the two parts, as I see it. There's the chief complaint, right, what you want to talk about, and then there's a time where the PCP talks to parents about the many anticipated guidance topics that are part of the Bright Futures requirements. So what I'm suggesting here is two things. One, considering opening that time frame up by using pre-visit data to narrow the focus of what's needed for anticipatory discussion. So if you're asking about safety and they're already doing checking the water and the right car seats and stuff, you don't talk about it. And you could also facilitate this, narrow the time frame by using targeted online post-visit parent education, not just a handout that's generic for the age group, that's targeted to the issue that's been uncovered by the pre-visit investigation. And then the other part I want to spend some time on is considering brief agenda broadening questions. We're going to narrow the agenda, and then we could broaden it. Let me tell you what I mean by broadening questions. And this is something I've been doing through my career, and it's been in Chattis. These questions. What's the best part of parenting that 4-month-old? What's the hardest? Those are pretty brief questions. That's for under 3. Over 3, we're suggesting, tell me about the strengths and talents you've noticed in Johnny so far. What has been the biggest challenge in parenting? So we want to get the positive things and celebrate those and acknowledge the parenting going on related to those things, and also being able to focus on a specific challenge that comes from the parent. And what we're talking about here is that parents may not feel that, may say, okay, I want to talk about this diaper rash, but not feel that this office is the auspices to talk about those things they've been talking to Aunt Millie about, the neighbors about, that's really getting under their skin in terms of parenting. So we're going to put parenting on the agenda. This is, by the way, these questions are pretty brief. It's even briefer if you let the computer ask it before the visit. So we've been doing this for a while, and I want to show you a little bit about how parents respond. We looked at 104,000 responses to the questions that I showed you. Let me just sort of summarize quickly. The hardest part of parenting, 0 to 3, top 3, top 1. This won't surprise anybody, but crying, fussing, tantrums, 21%. Sleep and managing other stress. Those are the hardest parts that parents endorse. And it was interesting that in the first visits, worrying about health was one of the items. There were 16 items they could choose from here. And almost 1 in 5 parents of newborns said, during the first month, that was a concern, but the frequency dropped precipitously at every age thereafter. Then once the kid is surviving, that's not what they're concerned about. We asked, what's the best part? 0 to 3. Number 1, the way the child smiles. Number 2, playing with him. And number 3 was watching him or her with siblings, because not everybody has siblings. But those are the top 3 out of 11. Now, I just wanted to show this. This is about that one about smiling. That was the top. And it wasn't just smiling, of course, starts at about 2 months, but it continued to be the most what parents liked, what they reported the best part of parenting over a period of time. That's number 1. We're going to come back to that. So for older kids, this is 4 to 12. We asked the questions of that said earlier about parenting challenges. Number 1, irritable, temper, moodiness. Number 2, managing behavior. And number 3 and 4 about school, worrying about school homework, worrying about learning. Those are the top challenges the parents see. And strengths, in the strength questionnaire, there were 20. We had the multiple intelligence, Gardner's multiple intelligence ideas, and verbal ability is one of them. But there are a variety of others, and the idea is to try to identify strengths and try to give kids opportunities and acknowledge the kids' strengths. Verbal ability and personality are the two top ones, and general curiosity about the world was the third one. And then we also had, I'll just quickly go over this, we asked them to write in some text responses. And we're in the midst of revising this questionnaire, but a lot of parents just had so many, I love every minute of it, the whole kit and caboodle kind of thing, that they couldn't contain themselves. We said, say one or two things. So they had to write this in, but also the board was, and that's good. Also, there were things about growth and development, watching her learn how the world works, the face he makes of awe or wonderment when he discovers something new, statements related to parental enjoyment of interaction, holding, cuddling, so forth. And then what we overlooked, I don't know, we did this a while ago, but we overlooked something we shouldn't have, the time balance issues. And that was really big. Parents wanted to talk about that, work, child care kinds of things, but also finding time for myself. And then also there were things about finding a schedule for the day. So that was the issue. And then a general feeling uncertain about how to parent. Am I doing the right thing? We had an item about feeling if I'm a good enough parent, but they wanted to tell us more about how to figure out not only how to respond to their moment-to-moment needs, but sort of how to do the right thing, solve the unique problems that parenting kids present to parents. So some ideas about how, so we've got these questions and how do we respond to it? We see two things. One, there's an acknowledgement statement. and for example, the most common thing was how he smiles. So you could say, I see the way he smiles has captured your heart. Then we want to acknowledge the parent's effort. I can see why. When you smile back, you're teaching Sammy about human affection. Can't think of a more important life lesson. So that's kind of an acknowledgement statement. And then some ideas about how to respond to the challenge statements, the hard parts. And first you want to reflect. It looks like being exhausted is your biggest parenting challenge now. First, we think you could normalize it. Many parents find babies can take every bit of energy. And then being open to more serious issues. And there may be other reasons you're so exhausted, you're pausing enough to listen to the parent. Okay. And then offering some help now and getting the help you need. And then deferring to the Chattis memory book for post-visit for general suggestions. Some strategies that help other parents survive exhaustion are going to be put in your Chattis memory book. And then offering future availability. But please let us know if there's anything we can help you problem solve further, things like that. So what we're doing is putting parenting on the agenda. Again, we're broadening the agenda for that visit, but also broadening the auspices for the future, lowering the threshold to spontaneously come up with something later. Communicating willingness to talk about the concerns that they've discussed, again, with a trusted friend or relative, and trying to be one of those trusted people. To be a trusted person, we have to not, and this is where I come down against screening, not treat them like they were a screen-positive pathologic case, but we're building a relationship, and a relationship is that there are positive things and there are difficult things. And we need to know both. If we only know about the negative, that distances them from us in relationship, our relationship. So, while I said that we're going to lower the threshold for spontaneous disclosures, we also are thinking, oh, you could use the ACE questionnaire, but not with screening. I'm going to tell you what I have in mind by that. And when would you want to use it? You want to use it really early before bad things happen, right? But after the major health survival issues of the newborn period. So we think maybe the 1 month visit. 1 month visit is good because it's just prior to the peak of child abuse deaths related to colic, the real parenting challenge of a screaming kid, which peaks at about 6 weeks. So we want to think about it as an educational opportunity. We want to avoid focusing on pathology, but also asking about a history of positive experiences, again, to treat them like a human being, not a pathology case, because people aren't all one or the other. If they had a bad environment, they had nothing good ever happen to them, there's maybe not much we can do. We really are needing the strength part to ally with. So we wanted to add a resilience and positive parenting questionnaire. So we put together this one. The first 4 have come from a positive experiences questionnaire that exists and showed that individuals with good scores on things like growing up, would you say your relationship with the biological father was excellent, very good, and on the good side? How often did someone give you a hug when you did something well or when you were very good? How often were you told how great you were? There were some other resiliency questionnaires that we wanted to pick up on things that people could actually do. And when I was little, people helped my mother and father take care of me, and they seemed to love me. I've heard that when I was an infant, someone in my family enjoyed playing with me, and I enjoyed it too. When I was a child, there were relatives in my family that made me feel better if I was sad or worried. So we want to offer both of these questionnaires the same experience. So how would we reflect back and report on this non-screen that we just did? And what we call shared decision making, a way to show parents the results, and they really have to decide what to do next. This is not you've got to do this because you're going to get diabetes. No. This is a portrayal of Jason's mother's experience growing up. This mother did the ACE and had 4 bad things. Probably that's not a good thing. 4 stressful events, and 2 really good things happened to her. So we could reflect on that with the parent, is what I'm suggesting. And then maybe at the 1 month visit. And here's an optional view where there's the actual events. Mother's was a partner victim, mother's mother, that is, there's a parent in jail, there's a lost parent, and being put down. On the other hand, this mother experienced playing as a baby, played with as a baby, hugged when they did something good. So we're not sure how to talk about these things, and we're going to be asking these parents and asking other experts. But the essence is that there's some routine education. Like you may have wondered why we asked you questions about your own childhood. The American Academy of Pediatrics asked doctors to do this because a large amount of scientific data showing that stress on children, especially early in life, can cause long-standing nervous system changes that can result in diseases later in life. Parents can protect children from stresses rather by comforting them and joyful play, such as someone did to you by playing with you as a baby and being generous with hugging. And it turns out these positive experiences act like a kind of protective immunization to stress, somewhat like the shots we give to protect against infections. And you will want to pass on that part forward to Jason. And then commenting on the parent's own ACE. Looks like you had some really tough times growing up, which may be affecting your health. You need to take good care of yourself. Jason is another reason to do so. Let me know if we can help connect you to helping resources for yourself at any time. And then a specific anticipatory guide, especially if there's some ACE. So this is the moment before the peak of colic. By the way, well, let me come back to that. This is when it's also the peak of the shaken baby syndrome at the same time that crying is at peak. So babies can be a source of stress, but also a healing joy for you. Unfortunately, in the next few weeks, your baby will be in the most difficult age. It's not teenage years, it's the colicky period. The babies cry as much as 3 hours a day. And when they go through a period when their nervous system is maturing, dealing with crying is what parents find to be the hardest part of parenting. The most important thing to know is it takes more than one person to work at comforting babies through this very difficult time, using a very gentle rocking and sucking sound, for example. The good news is that sometime during this difficult period, your baby will begin to smile, signaling it will be over in a few weeks. Learning how to get more smiles is the best way to help your baby. That's what most parents say is the best part of parenting. Remember, that's what we got in our survey. Smiling was the best thing, crying was the worst thing. And then a mention of how to access post-visit education. We're creating a memory book for your baby where we will put in suggestions for the educational and stress-protected play based on questions about Jason's development that we will ask you to complete before each visit. Making a baby book of accomplishments to celebrate and a place to give you suggestions for appropriate doings for your child at the time. Something like that. So that's what we're talking about is this. Can you see this? What I call developmental prescriptions. So in Chattis, when you're doing, you don't need Chattis to do this, but if you're using Chattis, it's easier because when they do the ages and stages, we take the milestones and put it in this memory book, this virtual baby book. And then there is a place called suggestions where they can click and they will get an idea of a little game to play with the child based on the fact that that child has this developmental capability. And if it's a new developmental milestone, the baby will think it's really funny and it's educational. And more than that, this is a intervention of seducing the parent to engage in a pleasurable two-way interaction with their kid. So we're getting them, we're providing a curriculum to do that. So that's the part of our thinking, okay? We want to broaden the agenda. We want to review early on ACE and protective factors of the parent. But then we're thinking you want to find out about the parent's own ACE, not from their childhood. I mean, it's the child's ACE right now. What's happening with the parent himself. So our approach to that has been to use the SEEK screen. It gets at food insecurity, parental depression, parental substance use, life stress, harsh punishment, intimate partner violence. Now, this is a 13-item simple screen. It's based on 2 positive randomized control trials in primary care pediatrics, suggesting that there's a reduction in child maltreatment. What we've done is add something we call the C+, because these are issues that really require evidence to say a motivational interviewing approach, because we're talking about conditions we're screening for that people have mixed feelings about. You know, are they really going to make the difficult health behavior changes? So motivational interviewing, but that takes a lot of time. It takes training, and so what we've begun is to create first the SEEK Plus, that if they're positive on the SEEK screen, the computer begins a motivational interview and asks about how bad things are and what they would do if things got worse and what their barriers are, things like that. And create teleprompters. You know, President Obama and even Donald Trump is now using teleprompters to talk, and doctors to do it too, at least they have an option to do it. Where there's difficult conversations at the time of the visit, and also creating post-visit messaging, local referral if needed, as well as options for clinical doctor, CME, and MOC. So here's the 4-month visit. they were sharing with the parent. This parent was positive on intimate partner violence. So the motivational interview began, and we have the pros and cons framed in this balance beam here. And on one hand, doing nothing has a risk. It's already affecting your sleep and threat that came from the computer. We are also, will soon, we're not doing this yet, pull the ACE response if it's related to something. Your mother had a similar experience. If you were an attentive primary care doctor, you would probably remember that, oh yeah, I remember your mother. And you know, the old people would remember the mother from before. I remember your mom went through the same thing. This is tough. On the other hand, in this case, the parent had in the pre-visit, computerized pre-visit C+, the parent identified a barrier that if she did anything, the partner may get mad and make things worse. So those are the pros and cons. And this is a screen that shows the teleprompter that's related in the Chattis family stress module. So, you know, here's some words, and our thinking is that if pediatricians or any clinicians practice the words, it slips out their tongue a little easier, but this follows the framework now that we're right in the crux of the motivational interview. I see you're worried about your partner getting mad, an empathetic statement, you're right, doing something about the problem has risks, and then it sounds like while you're in a difficult situation, doing nothing has significant risks and so on. So I'm going to